Good afternoon, ladies and gentlemen. My name is Jean Fajadet, and I have the really proud and to share this session with my friend Ibrahim Al-Rajdam, and we have three discussions: Himad Al-Haddad, Fahad Bazlet, and Hamad Eman. So the topic today is to discuss the role of renal denervation in the treatment of patients with hypertension. The role will be to try to understand and to really fix first the technology, second the patient who could be helped by this technology, and then the way to really open what we call a specialized hypertension center, which will be, we will discuss that, certainly the main solution to really increase and implement the role of this procedure. So this session is really particular because it's a sponsored session sponsored by two companies, Medtronic and Record Medical, and I would like to thank them to give us the opportunity to organize this wonderful session on this wonderful topic. So what I will try to show you is, in the very few slides, it's the impact on hypertension to the disease and what we call mediated organ damage and cardiovascular disease. And you can see that a patient with hypertension, high degree hypertension, high stage of hypertension, we have the risk of side effect on the brain, all the artery, large and microcirculation, the kidney function, the heart function, and the eyes. So it's a multiple mediated organ damage, and that's the reason why we need to, one of the reasons we need to take care carefully of this patient. When you look at the risk of hypertension, and particularly the cardiovascular risk, we can see that this risk is according to the grade of hypertension, and second, the stage of hypertension. The grade is defined by the level of systolic and diastolic aortic pressure. The stage is defined by the association of the risk factor from 1 to 3, and the grade is from high normal 2 to 3. And you could see in red that when the grading is increased and when the stage of hypertension is increased, the risk, the cardiovascular risk, is very important. And so that's the second reason to treat this patient. Another point is the cardiovascular mortality. We do not talk about morbidity, but here we are talking about mortality. And this is really impressive to see that the mortality rate is double for each 20/10 increase in blood pressure. And this, you could see on the slide, that the risk is multiplied by 2 at each step of hypertension. So, damage for multiple organ. Second, the risk of cardiovascular disease. Third, the cardiovascular mortality risk. That's the reason why today, the recent guideline, this is a guideline 2003 from the paper mentioned by the European Society of Hypertension, show that now we have two indication, and for certain patient, 1C indication. This is confirmed by the ESC guideline recently shown in the Euro Intervention Journal and the Journal of European Society of Cardiology, which is now 2B. So definitely we have a high risk, particularly cardiovascular risk, mortality risk, and so that's the reason why now we have this technology in the guideline for treatment of patients with hypertension. So now we can move to the first talk given by Ahmed Haladad, and he will talk about the history. He will come back also on the result and the guidelines of this technology. Ahmed.
Good afternoon for everyone, and thank you for being here. Thank you, John, for this nice introduction that makes my life easier in convincing you that we need new technologies and breakthroughs to treat hypertension. The prevalence of hypertension in fact, very high all over the world, across all genders and all socioeconomic classes. And it is the #1 cardiovascular risk factor, with estimated 1.5 billion patients will have hypertension. So it is a very, very common disease. Now, Dr. Vajday mentioned the risk of increasing blood pressure, but don't underestimate that minute decrease in blood pressure control will translate in a significant saving of lives, whether it is cardiovascular mortality or stroke mortality. So for every 2 millimeter of mercury decrease in the blood pressure, you have 7% reduction in cardiovascular mortality and 10% reduction in stroke mortality. So don't underestimate even minute reduction of blood pressure. As we know, hypertension is a chronic disease. Duration and severity is extremely important. If you add to that other risk factors, you will end up with a huge mortality, as John mentioned in his graph. Now, why we need new therapies to treat hypertension? We have a lot of classes that we can control blood pressure. But I'll tell you here, despite the treatment and the lifestyle modifications, we still have a lot of patients that did not have good control. So in the United States, only 1 of every 4 patients have a good control of their hypertension. The second thing, many patients, they have other unaddressed risk factors that need a stricter control of blood pressure. So if the patient does not have other risk factors, you have a leniency of your blood pressure control. But if you have other risk factors, you need to have a very strict control of blood pressure to decrease future events rates. The third thing is, although we have many, many medications, but a lot of patients, they cannot take these medications or they don't adhere to the medications, particularly those patients who had other cardiovascular diseases or other diseases that they need multiple medications. So it is very difficult to take multiple medications at the same time. True resistant hypertension is very common, and it is estimated between 15 to 30% of patients, they have resistant hypertension, despite the availability of all classes of hypertension. So you have to pay attention to those patients. So with this, novel approaches are badly needed to achieve blood pressure control. So despite aggressive medications we need new therapies and new novel approaches to treat these patients. Renal system sympathetic activity and hypertension is well described, and it is depend on the level of the activation of the sympathetic nervous system. Low activation will lead to renin activation and release. Moderate level of activation increase sodium reabsorption, and highest level is associated with vascular resistance increase. So you need multiple approaches to sympathetic to denervation to treat that. Renal nerve denervation is a potential therapeutic alternative to adjust pharmacological therapy to control blood pressure. And as we know that surgical denervation decades ago provided an excellent control for blood pressure, but it was associated with significant side effects. It was abandoned. So now we are looking for percutaneous denervation system and approaches that will be ideal to denervate the sympathetic renal activities and provide a better blood control to this. So I remind you, this technology is not new. And we have the rise and the fall of the Simplicity Flex RF catheter, because we have a lot of hype initially, and we did not have a proper randomized clinical trials. However, with the data from the Simplicity trial, that technology died. And I think we had a lot of hype. We really promoted the technology before it was mature enough to do that. So we have a great achievement initially, but that was abandoned as subsequent publication. However, I'll tell you why we failed initially. First of all, patient-related selection bias. We have true resistant hypertension was not well recognized. Intolerant to medications, very important to select those group of patients. Patient or procedural related factors, extent of denervation, we did not know how much we need to denervate, and the depth of denervation was not very clear, so we have real issues with the procedure itself. And then the devices. We have only one simple device and with simple catheters. Now we have a radiofrequency, we have ultrasound related, and we have ablative therapy. So we have multitude of different issues we need to address to improve the technology and to get what the results we want it to be. Now patient selection, we have guidelines now to address those patients with resistant hypertension, to exclude patients with secondary causes of hypertension, and then you need a multidisciplinary approach, and that's why we need hypertension centers, and whether you need to provide patients with medications or to refer them to denervation therapy or combination of both. So this has to be addressed and has to be really formulated to better selection of patients. Now we are in the stage of precision medicine. So things can be done very accurately with CT angiography to know where to denervate, whether it is a main branch, length of the artery, side branch, and so forth, accessory renal artery, and so forth. And on top of that, we have more devices available to us nowadays. We have the Medtronic spiral system, and we have the Core Paradise system, depending on ultrasound, and they are both FDA approved. And we have lately seen something related to alcohol ablation, which is in the early stages of renal denervation. So we have more devices and more technologies that are available now that we can utilize. Now, this slide will talk about the selection of the renal denervation. We know that before 2014, with the Simplicity 3, killed the technology, but nowadays with the 3 different devices and with more accurate denervation, we are seeing the life coming back to renal denervation. And this particular presentation today and this symposium will address likely the multitude and how we can initiate and how we can benefit our patients. We have a great speakers here that will address different aspects of the technology and patient selection and the clinical data. And then hopefully that we will end up with really clear message at the end of the day. Thank you very much.
Thank you, Ahmad. Please ask questions. This is an interactive session. It's a forum. You can ask through the application or come up and we will hand you the microphone.
Any question? First in the audience on this first talk, introducing the technology.
Actually, I have a question for
you.
So, what do you think the causes of regain or back life to the RDN after the HTN3 trial back in 2013? So what happened to change everything?
I think 10 years is a lot of time to rethink and reconsider and really provide a proper approach to renal denervation. We know that we have a lot of patients that have resistant hypertension. We believe in the pathophysiology and we believe in the need of that. And we also believe in the therapeutic intervention. Surgery provided excellent control to hypertension, but a lot of side effects. So this is, if we do it in a precise way, different technology, whether it is ultrasound or radiofrequency ablation with proper ablation. Because when you go inside with a stenting, you know that you open the artery, do FFR, IVUS, you have patent vessel. But here we don't know how much we ablate, how deep we need to ablate, how long we need to do that, and also different understanding of the expectations of the technology. So that helped us, the resurrection of the new technology.
We have a question from Hazem Khamis.
Thank you, Ahmed. I think one of the many challenges, there is no actual predictors for successful denervation. We have no biomarkers, we have no angiography evidence. So I think this is a main problem for this technology. You do a lot of ablation. The new thoughts ablate distal to the bifurcation before we ablate the main vessels. Don't go to the renal parenchyma. Do a lot of ablation, 14, 16, 18 ablation with the new devices. But at the end, we did the ablation. But how can we predict? There is no actual predictor for the successful ablation. This is a very important issue.
That's a good and really important question. And Hazem, we will come back to this question in a few minutes, okay? After results. So now it's time to call Rasha, and she will talk about the clinical experience with radiofrequency renal denervation.
Thank you so much. It is a pleasure to be here and dive deep into the renal denervation. So these are my conflicts of interest, and we'll move on to a case immediately. So this is a 43-year-old gentleman. He has uncontrolled hypertension, coronary artery disease, presented with non-STEMI a few months ago, had PCI to the LAD with borderline LVAF. So his secondary workup was negative in terms of hypertension workup, and he's still uncontrolled hypertension both with the ambulatory and office blood pressure. He did have an admission with hypertensive emergency between his last admission and now. As you can see, his medications, he's on 4 medications, including a thiazide, and the question is, what would you do next? So if this patient came in 10 years ago, it's different than what his presentation currently. So just by show of hands, how many they would do a renal denervation, and how many would just say, treat him medically? Okay, so a few hands here and there, a lot just waited. Hopefully after the session, we'll have more answers. So just to remind you, this is someone who's resistant hypertension, already on 4 meds, and he's a really high-risk patient given that his recent presentation, young guy. So if we just briefly talk about the guidelines, 2024, so 2018 is not recommended because we really didn't have much of data after what we discussed earlier, the old sham control trials. But with the recent data, the 2 main indications to treat is if you have, it's a class 2B indication. 1, if you have resistant hypertension on 3 medications, including a thiazide. And if you have uncontrolled hypertension, even if less than 3 medications with the high-risk patients, given that this decision should be made with the patient in the setting of multidisciplinary assessment before. So we opted to go ahead and treat him. We used the Simplicity spiral catheter. So one thing to remember, I think we're going to do more step-by-step procedure, step-by-step technique in a second. But the most important thing is these procedures are actually very painful. So you really need to have adequate sedation. It's a femoral procedure up until this date. Maybe things will change in the future with different length catheters. We typically do non-selective renal angiography, not necessarily needed in most of cases if you already have really good CT. It is a 6 French compatible. This was just a 7 French that we used in this case. And you definitely need a shorter catheter, guiding catheter, just because of the working length of the radiofrequency ablation catheter. You take your selective images, you put your guide wire as deep as possible in the branches as we talked about, and you start deep. One thing about the RF ablation catheter is that it comes with the 4 dots that you can see, and each dot is reflective of these 1, 2, 3, 4. You can go ahead and select one of them to be done if you in the setting that you're not happy with one ablation, if it stops in the middle. And the idea is that you don't treat the same segment twice. So with these particular catheters, it gives you the variety of actually treating different segments and without having to do an overlap or treating a segment twice. So moving on to the same patient, so this is what his office blood pressure was, 158/86. 3 to 6 months later, his office blood pressure dropped. We typically do ambulatory blood pressure. Unfortunately, I don't have it for this patient, but it's a better indicator of if they responded or not. It would be nice to ask the panel later with the rest of the speakers what the response that you'd like. There are some studies that said less than 5 in an ambulatory, less than 5 in a systolic blood pressure and ambulatory blood pressure is considered some sort of a good response. But what's important in this case, we typically don't really change their medications up until 3 months when they show up. But this patient showed up at primary care where they really decreased most of his meds. So if you can see, bisoprolol was cut really down to 2.5. Valsartan switched to perindopril in a lower dose. And he was taken off thiazide and amlodipine, not necessarily what we would typically do. And in this case, we actually added in indapamide because we still think that he needs a better blood pressure than this. But it really helped to get us to a much better hypertension control. Just briefly, Dr. Ahmad nicely illustrated that we had really well-conducted old sham control trial, kind of killed the older generation of RF ablation. And since then, from 2014, 2016, these were published and reflective in the guidelines in 2018. So what really changed since then is that first, we really have better technology with second generation RF catheters. We do have the ultrasound-based catheters that we're going to talk about in the next half of the session. And also the trials were conducted on a broader patient population, on and off meds, to proof of concept that it really works for these patients. And there is actually longer-term data, even with the previous trials, that there is a sustained and more reduction of blood pressure beyond the 3 and 6 months that we typically talk about when we talk about response. And although all these trials did not really look for safety endpoints or powered for safety endpoints, there are actually no major safety endpoints. This is the hypertension on and off meds. Both of them showed a reduction of blood pressure, about 9 millimeters mercury in the RF ablation arm on meds, and about difference in about 3.9 in the off meds in terms of ambulatory blood pressure, systolic blood pressure. This is just to illustrate what we talked about earlier, is that there is this sustained and more durable blood pressure lowering beyond the first year as well. And if you look at just a spectrum of registries and data, the drop in blood pressure could be as high as 30 millimeters mercury, but even down to less than 10 years, you can still see sustained blood pressure response. So it's not just a one-time effect or one-year effect that you have to do again. So in summary, RDN is effective in selected patients. We do have better technology. We have better trials nowadays that prove it. It is sustained with longer-term blood pressure reduction beyond 3 years. And there are overall no major safety concerns from all these trials that we've had so far. It is also a limited technology. So what we know so far from meta-analysis and all the literature overall, yes, there are some super responders and they're not. So in average, it comes down to one medication. And the reduction in systolic blood pressure is about 6 millimeters mercury in office-based and 4 in an ambulatory blood-based pressure. And there is overall, we do think that obviously lowering the blood pressure does reduce the cardiovascular outcomes, but these data or these trials were not powered to detect clinical outcomes. So with that, we'll conclude my presentation.
Thank you very much, Rasha. Now, we had the questions at the end, but we thought bringing to each speaker the questions, so we have room for 1 or 2 questions maximum. Short questions and short, please.
So thanks, excellent case. The thing is, how is it required in each and every case to scan for the secondary hypertension or not? What is the schema for scanning the secondary hypertension? What is the phenotype of these patients in which you will scan for secondary hypertension, or you just label them as a resistant hypertension, 3 drugs, more than 3 drugs, and take them, if they are not responding to the drug therapy, take them for the renal denervation?
So,
Rasha?
if I may, just, regardless of whatever therapy you're going to use, secondary hypertension should be evaluated in all patients. So anyone who comes in hypertension, they should actually have the whole workup. But we know that this is only a minority of patients. 10% will have an explanation to their hypertension. For us, the concern is most of these patients might have renal artery stenosis if they have cardiovascular. So a real thorough workup, including renal Doppler ultrasound and CT, would help kind of differentiate those patients before you bring them to the lab.
Thank you, Rasha. Yes.
Thank you very much. Would you mind adding spironolactone or other MRI before deciding renal denervation? Because sometimes, the choice is to give another diuretic, including, for example, spironolactone or eplerenone, before deciding the renal denervation?
You can. There's always that option of adding more medications if you discuss with a patient. But spironolactone on top of valsartan or perindopril in someone who has normal EF is also, it carries its own risk too of hyperkalemia and AKI, plus the gynecomastia with spironolactone that we've seen in our patients too. So if you have that discussion with a patient, they're happy to do it. But I doubt that spironolactone, in addition to everything, will drop the 158 to the numbers that we got with just one medication. So.
No need for individualization. For example, if the patient not ready for renal denervation, need a multidisciplinary team.
Absolutely. So that decision was not made on the spot with the patient. So it's a decision that we sit down with the patient. They're actually, most of these patients, when you talk to them, they're really bothered by adding more pills. And the fact that he actually just came in with ACS, we already have aspirin, statin, antiplatelets, and he's a 40-year-old gentleman. He was actually on carvedilol to start, was switched to bisoprolol because he wanted one-day medications. So it's really hard to kind of sometimes add more when they want you to take off medications.
Thank you.
Thank you. Thank you. Thank you very much, Rasha, and thanks for the question. I agree with the gentleman. Adding spironolactone is very important, I think, and you have to be careful about hyperkalemia anyway. So with that, I would like to call Dr. Khalid Al-Johani to speak on technology, how RF renal denervation works.
Thank you so much for the invitation. My name is Khalid Al-Johani. I'm an interventional cardiologist at King Saud University. I've been given the task to talk about the technology for the one that currently available in the market in Saudi Arabia, which is the Medtronic RDN system. I like technology. Well, this is my potential conflict of interest. I'm sponsored by Medtronic. Renal denervation as a therapy, it's not which most people think it is, like a first-line therapy. And even now at the level of the population themselves, they're coming to the clinic, they're asking, I want this fancy treatment for my hypertension. It has to be, because all the evidence said that you have to take the stepwise approach in treating your patients by, most importantly, often forgotten in the clinic, the lifestyle modification and its effect, like weight reductions, healthier lifestyle, taking some herbal remedies and some stuff that can help reduce blood pressure effectively in some of the population. And then you can introduce one, second, third, and fourth line of treatment. And this renal denervation is intended for the group of patients when they are resistant. And just to mention, actually, a subgroup of patients that are often forgotten, which I do face a lot in my clinic, in one of my women heart health clinic, the women in reproductive age, they don't want to be on antihypertensive drugs because they want to get pregnant. You know, the hassles of getting this off on medication. Renal denervation could be a viable option for treatment and reducing at least the pill load for them. Going back to understand the technology, we have to understand the pathophysiology. So all of you know that it's a connected system between the brain and the kidneys with the renin-angiotensin system. The brain modulate that through the sympathetic tone, release more renin, and that by itself cause more sodium retention, which eventually lead for hypertension. So the idea is, which was mentioned before, that taking off that nerves, which is the easiest to be accessible, to hopefully cut that circle and maybe reduce the blood pressure. The Simplicity blood pressure machine, which will go in details in the next few slides, that's the beauty of industry. They take whatever failure they had, they improve it. They knew the limitation of the previous generation, and they try to accommodate it into a newer generation one. And the process is ongoing. They always try to update and try to change to the patient. They always listen to the doctors when there is a problem. They try to adjust to the patient population they are treating. So the catheter, as mentioned before, it's a 5 French, compatible with the 6 French, usually femoral procedures. The 6 French radial coming soon to the market. I think it's the US soon to be released, where you can do it as a day procedure and you can even discharge the patient on the same day. It is made of 4 golden-plated radiofrequency markers. Usually they're separated by 6 millimeter in between, and it's radio-opaque. You can see it clearly in the fluoroscopy. And the aim is to increase the heat in the perirenal artery fat, which will ablate the nerve and causes, hopefully, the cut of the cycle shown earlier. The beauty that it's actually spiral, it's versatile in a way that it accommodates with the anatomy, because if someone saw the anatomy, if you're not familiar with the renal anatomy, is so variable. And sometimes even some patient, which I advocate for, to do a CT scan, because sometimes you find an accessory artery coming down from the iliacs, where you have to ablate if you want to have the effective treatment, because it's a branch going into the kidneys and it has nerves that can cause hypertension. And the beauty of the new catheter also that it is accommodating the average size of renal arteries between 3 and 8 millimeter because of its helical appearance. It is very safe, and it has safety point because, again, you're here to treat the patient. You don't want to cause a problem. You don't want to create another problem like dissection, any damages to the renal artery, and then you go back to square one and maybe even worse. The system is very effective in turning off by itself if it reaches a certain point of impedance and certain point of heat. And often we see it when the artery gets spastic, the heat go high, and it's actually on a live monitor. You can see it on the screen. When the temperature rises to a certain level, it turns off by itself, indicating that maybe there is a spasm, or maybe you're in the wrong place, or maybe you're not attached effectively into the renal arteries. Where it's seen in the 4 dots, you can actually, sometimes you can repeat it, turning off the dot that was heating excessively. This is a diagram showing that a safety margin for the ablation spot when it turns off exactly when it reaches a certain level of heat that it will cause damage. And in contrary to the previous belief where we usually ablate the main arteries, now they are advocating, and based on evidence, to try to ablate as distal as possible, but not too deep to the parenchyma, with evidence supporting that when you do this procedure, specifically with this newly designed catheter, you achieve more ablation and more effective treatment. As shown in this combined treatment, when you treat the main and the sub-branches, the effect on denervation is higher, where it was studied on pigs, and you can see the atrophy in day 60 of the renal nerves when you ablate them effectively through the catheters. So in summary, renal artery denervation, it's a radiofrequency system, and it's safe and effective. It has to be combined safety and effectiveness. Renal artery denervation, it's versatile. It's one size fits almost all based on this new design. And it's used as an adjunct to therapy, never as a standalone, never as a first line. And soon we'll be seeing the renal artery denervation via radial approach, which will make the life of the patient easier as a one-day procedure. Thank you.
Any questions? So if we have no questions, I guess we move to the next.
We can move to the next talk that we call
Till now, we don't
question.
have,
Sorry.
Yeah, till now, we don't have a way or a measure or escalation or anything that the ablation is successful.
Yeah, that question was asked before you came to the room, and we addressed that question a bit later. Thank you very much. So that's a $1 million question.
Wait till the end.
Yeah.
So I will call Dr. Ronay Santouf. We talk about the RF renal denervation procedure step by step.
Second by second, we'll go. So thank you very much. It's an honor to be here with everybody and esteemed colleagues. Here are my disclosures. So we'll sort of build on the first 2 talks in regards to the step-by-step procedure for RF ablation. So we essentially are using, there's 2 components to the device itself. So you have the spiral catheter itself, and you have the RF generator. And that's kind of it. It's really straightforward in regards to what you're using. These are sort of the agenda and the steps. We'll walk through each step and the procedural flow and talk a little bit about the process itself. So in specific, six French guide is all we need. You don't necessarily need a bigger guide unless you have a very specific, you have a specific situation with the patient. Short guide, as recommended from Dr. Russia mentioned, so 45 to 90 cm. Usually an IM guide or an RDN guide or RDC one will be helpful. A lot of times the company will have that and be able to get that for you to facilitate. Your standard 014 guide wire, something like a workhorse wire that's got a safe floppy tip that has some support and body to allow to deliver the device. And you're essentially going to have your denervation catheter, which is the spiral catheter, Simplicity spiral catheter, and the generator, which you're going to connect the catheter to. There's dispersive electrodes that are going to go on the patient for grounding. In regards to the catheter itself, it's going to, standard, comes with a package. You're going to take it out. The key thing to remember is do not flush the catheter while it's in the hoop or in the catheter lumen, and do not wipe the spiral catheter section. Leave that part alone. Just take it out of the hoop. You have the coil cable that you're going to pass on to the team to connect to the generator. You're going to have this, you can see the straightening tool over there in the middle of the screen. That's going to allow you to straighten the catheter to feed the wire. I think one of the key things, and as mentioned earlier, is the understanding of the renal nerve distribution around the renal artery, and this really helped to reshape the thinking of the procedure itself. And so initially, initially thought that the nerves are essentially, the distance between the nerve and the artery is the same, whether we're talking about the proximal segment to the distal segment. We now have a better understanding where really these nerves are coming in and coalescing around the artery as we move more distal. And this changed the concept of how we do the ablation itself. Now, the other key concepts to understand that our accessory arteries also nerves are supplied to it. So the process itself. First thing to think about is, of course, the anatomy. You want to understand the anatomy, whether that's done by CT or angiography at the time of. You really need to lay out the lay of the land so you understand, are you dealing with two renal arteries? Do you have extra accessory arteries on both sides, on one side, so that you can make sure that you have a plan? The second aspect is to understand, when it comes to RF ablations, to understand how many branch points you have, and also where your renal calyces are. So we'll show you in the next slides. It's very important to sedate these patients. As mentioned earlier, it is painful, so you want to work with timing the sedation to make sure, or give some sort of pain medication for the process. The next thing you want to do is really plan the treatment area, so you understand exactly what parts of the renal artery you are planning to ablate. Sometimes it's helpful to get a pen and a marker as you do your opening shots. You can even just mark it up on the screen. And then standard approach, get a sheath in, 6 French sheath, take your guide up, do a non-selective if you don't have initial anatomical description before, and then insert your guide catheter and advance your guide wire distal into the renal parenchyma. Target an ACT of greater than 250, and then you want to, the overall plan is to go distal to proximal, and that's the key thing. It's sometimes helpful to give nitroglycerin to prevent any spasm during the ablation. Finish one artery, move to the next artery. So again, here's an example where you did an aortogram was done because there was no pre-imaging done before, and I think this is a great point of discussion as we go about whether or not to do a CT beforehand or at the time of. I know that there's different approaches regarding. The arteries that are treatable are essentially those that are between the size of 3 and 8 millimeters in diameter, and these are what you're going to consider for treatment. This does include the dual renal arteries, accessory arteries, and arteries that are at bifurcation points, so not just the main artery itself. The treatment should be outside the renal parenchyma. It's helpful to have a selective shot of your kidney and make sure it's in an angle where you can actually see the parenchyma, so you can really understand how distal you should go, because you want to avoid ablating inside the parenchyma itself. And again, as we mentioned, go distal to proximal. In terms of technique, you want to make sure that there's a treatment, there's at least a 5 millimeter distance between your ablative points. And so if you're thinking about the overlap, if you sort of look here step by step, you have your spiral catheter placed here, 1, 2, 3, 4 dots. You've done your ablation, and you're going to look at here's a different point for ablation. Actually, so if you compare this one to this one, you want to pull back your catheters to make sure you are not overlapping. However, if you have to overlap because of the way the structure is or the length of the vessel, you simply can turn off which ablation points you want to use, because you have 4 different ablative points. And you can see over here, you select exactly which ones you need. So here's a particular scenario. So for example, in this particular case, you have an ablation that was done 1, 2, 3, 4, the catheter. You pull back the catheter, use your guide wire to help straighten and pull back, and typical using your interventional skills that you use in the coronaries, you're simply going to pull back your catheter. Your distal point is going to be an overlap from the most proximal point of your prior ablation. So in this case, you would just shut that off and do the last 3, and then continue on in your renal artery, either here or here if that hasn't been done yet. What's nice is with the RF system, you are going to be able to save all your ablation points, and you're going to know exactly how many ablations were done. This will help, of course, for the treatment summary and just if you're part of any registry, for example. And that's really the step. It's relatively straightforward, which is really nice and elegant in terms of the procedure and process. Thank you.
Thank you, Ronnie. Any questions for Ronnie? Yes, Hazem. Mike?
Just additional steps for the procedure. Usually, those patient is fasting, long-standing, on diuretics. Once to anesthetize or give them conscious sedation, they have severe hypotension inside the cath lab. So those patients, any patient with renal denervation need hydration, very good hydration for this point, because when there is hypotension, the flow inside the renal arteries decreased, the heat inside the renal arteries using these multi-electrodes increase, and every time you will fail to ablate many parts in the renal arteries. The second, in my country, in Egypt, we have a shortage in the small length guiding catheters, especially the 90 or 45 centimeter guiding catheter. So we cut usually the right coronary guiding catheter or the Lima guiding catheter and attach this guiding catheter to 7 French sheaths, and you can use it as a guiding catheter for if you don't have the proper guiding catheter for renal denervation. Sorry for this.
Thank you, thank you. Thank you, Dr. Hazem. Dr. Ali Al-Slami, please come to the podium for your patient selection and referral, setting up an RDN program.
Thank you very much for inviting me. I'm Dr. Ali from Kuwait, interventional cardiologist in Mubarak Hospital. So over the last probably 18 months, we've kind of started doing some cases in our center. So I have no disclosures. So which patients are suitable for denervation? So I'm just going to be talking briefly about selection. It's a very straightforward talk, and it's very short. So patients obviously who have uncontrolled blood pressure, who have borderline control with medications, poor adherence to medications, especially with side effects related to that, and unwilling to adhere to the medications, there's a patient preference, or there's intolerance to the medications, and obviously patients who have elevated cardiovascular risks. So this is the general principle for patient selection. So essentially you have a hypertensive patient. Obviously patients who have secondary causes, they're excluded, so you just treat their secondary cause. And then those who have actual hypertension, you have to assess whether they have resistant hypertension, meaning their blood pressure is consistently elevated. And you have to assess their adherence and non-adherence to medications, and we'll talk about this. Whether they have elevated sympathetic activity or not. Look at their GFR. If their GFR is low, then they're obviously excluded. And patients expressing preference for RDN and whether they're suitable for RDN or not. So this is basically the pathway for referrals. So you can screen for patients in your center, and you can create like a referral system. So some of the key criteria important to them is you have to have a clear selection criteria, peer-to-peer program, feedback loop of communication and results, and patient returning for follow-up. So if you look at the right of the screen, this is the flow chart. So you have a patient who has blood pressure that is always elevated more than 130/80. The primary care physician should assess whether he's on optimal therapy. So that's very important. He's on an ACE or an ARB with a diuretic along with a calcium channel blocker. And whether he's persistently has elevated blood pressure. Then if that's the case, if he's on triple therapy and he's not controlled, then he should refer it to the hypertension specialist. So the hypertension specialist will basically assess whether he has resistance to drugs, confirm that he has uncontrolled hypertension, and that's very important. One of the main things that these centers should have is ambulatory blood pressure monitoring, and that's a very useful tool to have in your basically clinic. So I think for any patient, for any center that has a hypertension clinic, they should have ambulatory blood pressure monitoring available, because that's the only way you can exclude white coat syndrome or masked hypertension. The other thing is we talked about the screening for secondary causes. Based on your thoughts about whether this patient could have secondary cause. So if you've assessed that the patient has resistant hypertension, you can consider looking at his medications. One of the things that I find very important is adherence, and you can improve adherence by giving combination pills. And I'm sure there's a lot of combination pills available, whether it's triple combination pills or double combination pills, because that will really improve adherence to the medication. The other thing is maybe to add aldactone, because that's also very effective in lowering the blood pressure. Once you've done all of this and the patient still has resistant hypertension, then you can consider referring him to your procedural person, the interventional person, to do renal denervation. So these are the considerations. Just quickly, based on the guidelines, and we've discussed this, the guidelines have now included 2B recommendation for RDN based on recent studies and the effectiveness of the therapy. This is basically a physician recommended. How they looked at the scoring system and they saw what kind of score would you give them to refer them to RDN. And basically, the higher the blood pressure and the more the medications they're on, the more likely they would refer him for RDN. So basically, the consensus statements, so patients who have resistant hypertension, who have an office BP of more than 140/90, or confirmed ambulatory blood pressure of more than 130 over, basically more than 130 systolic, and treated with more than 3 medications and had a GFR of more than 40, can be referred for RDN. And maybe RDN is a possible treatment options for patients who cannot tolerate antihypertensive medications, who express a preference to undergo RDN, basically because they are not able to adhere to the medications. So there's multiple referral pathways going from the primary care centers to the specialists who are basically non-cardiology specialists, whether it's nephrologists, hypertension specialist, or a non-invasive cardiologist, going all the way to the interventional cardiologist or even interventional radiologist to perform the procedure. It's basically a checklist of things. It goes from the primary care centers to the hospitals to the outreach to basically the tertiary centers. Again, looking at the guidelines, even ACC guidelines.
Sorry, Dr. Ali, we just need to conclude as soon as you can.
Sure, I'm almost done. So this is basically the algorithm to refer a patient to RDN. I don't want to go through this. And then there's also some consensus statements that was published in in Spain regarding how to manage patients with hypertension and refer them for renal denervation. Thank you.
Thank you, and sorry for the interruption.
No, it's okay.
We'll pass the question to, because we're running a bit short on the time, so we go to the next speaker, Ronnie Shantouf again, to tell us about technology, how ultrasound renal denervation works.
Where are we? All right, so we'll catch up on time here. All right, so to talk about a different method, really this is looking at renal denervation, but an ultrasound-based therapy. We'll just talk about the technology itself. As mentioned before, we won't belabor the slide, but essentially showing the different points of where the renal nerves and how they coalesce as you go more distal into the radial artery itself, the renal. So what's kind of interesting is majority of the renal nerves are within 6 millimeter depth of the vessel. And so this kind of is what formulates the concept of the ultrasound technology. And the way that it's thought about is, one of the goals is, of course, to reach the nerves so you can ablate them and have an effective modality to enable to penetrate the tissue effectively to reach the target. 2 is to be able to ablate as many nerves as possible, maximize that treatment zone. And 3 is to ensure that there's obviously safety and you protect the endothelium as you go through this process. So similar to our RF, there's ablation, there's basically a generator and a catheter itself. So again, simple technologies. I think there's one of the part of the message here. The modality uses ultrasound to create heat, and it sort of does it in a cylindrical method. So you get a sort of cylindrical ring around the balloon catheter itself. And the catheter itself has a hydrocooling system within the balloon catheter that really cools the outer surface of the catheter, which then in and of itself cools the endothelium and protects it from the heat itself. So the idea is that this allows for deep penetration into the perivascular space, keep it as a circumferential donut around the renal artery, and protect your vessel itself. So here's sort of just a little view of what's happening. This is, of course, in a model, and you can see the thermal protection around the balloon itself. So the treatment zone is about 6 millimeters in terms of depth, and the treatment time is 7 seconds of sonication. That happens when you ablate. And this allows for a complete 360 ablation with the concept that you're hitting any of the nerves that pass through that ablative ring. So, as mentioned, the coolant basically allows the protection of the inner lining of the vessel. The transducer gives that 360 degree, and then the generator itself has an algorithm to automatically adjust the energy based on the catheter selection, which is based on the size of the vessel itself. So one part that's different than when talking about the RF ablation is that you're going to pick your balloon sizes, so you really need to know the size of the vessel that you're going to be ablating. So just before moving quickly to a couple slides on the clinical, it's very important to have the anatomy. A lot of times it's recommended to have it with a CT scan ahead of time, or at least do an angiogram, measure the size of your renal artery. And of course the treatment itself, which I think will be discussed in future slides, will essentially focus on the main renal artery itself. You do not need to go into branches, which is slightly different. In terms of trials, there's supportive data. You have 3 large randomized controlled trials. Two of them have antihypertensive washouts, so they're really off medications. And what was done differently than some of the older trials is no medication changes were done unless they escaped from the BP criteria that was established. And the TRIO trial was essentially a higher risk group with higher blood pressure on multiple medications. Follow-up was at 2 months. And you can see from the data here, you had consistent and persistent reduction in blood pressure. And it was nicely mentioned in the introduction that even 2 millimeters of mercury has a significant impact on morbidity and mortality. And what we can see here, if you're looking at different parameters of blood pressure, you have, again, a consistent and persistent reduction in your blood pressure. In terms of complications, the technology has shown no major signals in terms of short-term risk or even out to 6 months event rate. And what we see here is some long-term data in two of the randomized trials, and one of the a single-center study shows even data out to 8 years with persistent reduction in blood pressure. So of course, this should translate into a reduction in cardiac events. So just in summary, we have the ultrasound technology, slightly different. You have to pick your balloon sizes. The idea is to give a complete 360 ring of energy that will should target about 80% of your sympathetic nerves. The delivery is a 7-second delivery. You use about 2 to 3 seconds per main artery, and you go to each from the right side and the left side, of course. The system is designed to protect the endothelium, and we have also supportive randomized controlled trials for this form of renal denervation. And we'll stop over here. Thank you.
Thank you, Ronnie. Any questions? Yes.
Sometimes we have 2 to 3 arteries in one side. So you'll have used and different sizes for these renal arteries. You use different balloons and different sizes. How many balloons you will use?
We haven't encountered this issue, and I think this is where a CT scan ahead of time might make you think about the strategy in picking which modality if you have the option of multiple modalities.
Okay, the other question?
As regard the selection criteria, I'm an intervention cardiologist working in the private section in Saudi Arabia. Would be the non-adherence is enough to convince the insurance to cover this expensive procedure? This is one. And we started to have referral from our nephrology colleague with a GFR less than 40, and the patient is already readmitting with resistant hypertension, and he's already on 5-6 medications. How you will reply for this referral? Thanks a lot.
So, I mean, I think this is the referral questions, and insurance is great for the panel. From our standpoint, we have a systems and a team-based approach. So these patients are going through multiple clinic visits. They're going through endocrinology or nephrology to make sure that they're adherent to their medications. In terms of what was your other question in regards?
Non-adherent patient, how to convince the insurance to shift to intervention, and for the CKD below 40.
We don't touch CKD below 40. I know there are some centers in Europe that have some registries, and they're looking at some of this data, but at least for us, we don't. Anybody with a reduced renal function, we leave alone.
Regarding the CKD question, the reason they don't do it below 40 is because of the contrast issue. I think that's the main reason why those patients are excluded. And regarding the non-adherent patients with insurance, as far as I know, I don't know about Saudi Arabia. I was just wondering whether insurance covers renal denervation, because as far as I know, until in the Middle East, there's no insurance policy that covers RDN.
In Dubai, you guys have insurance coverage, Fahd?
Till now, we are working on it for the insurance coverage. So till now, we don't have insurance coverage. But soon it's going to be covered by insurance for the special criteria that's approved by guidelines. So that's what we are working on. Regarding non-adherence, I think that's a term that can be abused later on. So we have to be really careful if we need this technology to be successful.
Ahmad?
Yeah, I think this is an issue, of course. It's about how you implement and you put the criteria to choose the device for the patients. For example, the expectation of the decrease in the cardiovascular risk in the future to justify less or decrease in 10 millimeter that will translate it in the future risk, like more than 20% decrease in stroke, in heart failure, in MI. For younger patient, for example, this is a good start to start with the insurance issues. You are treating the cause, not treating the result of the disease itself.
Sorry, okay,
I had a question, if I may ask.
Yes.
My question was about the indication or referring patients for renal denervation. So one of the things that we need to do is to exclude a secondary cause of hypertension. And I just wanted to ask whether you do that at your center or do you refer them elsewhere? One of the challenges I find is actually excluding any secondary cause because some of the tests that we need to do would require the patient stopping a lot of their antihypertensive medications. So I wanted to ask you or anywhere else, what is your protocol?
It's an excellent question. First of all, it's a minority of patients who need to be screened for secondary causes. There's really certain criteria you can look at is whether it's a young patient and patients, for example, young patients who come with diagnosis of hypertension. That's one reason you'd look for secondary causes. The other reason is if you have a patient who's been well controlled on medication and then suddenly developed uncontrolled or resistant hypertension. Those are the patients you really need to focus on. You can't just screen all patients for secondary. It's too expensive and too tedious. And then if you do need to screen them, in my center we can do everything. We can look at the cortisol levels, the 24-hour urine. We can do the CT scan. We can do all of those kind of things. But generally speaking, that's how I would approach it.
Maybe I can make a comment. Joachim Weil from Germany. So we're doing renal denervation since 11 years. Now, I have done 400 cases in my career so far. I agree to you. There are not many with secondary causes. But in the new guidelines of the ESC, that say everyone needs to have an aldosterone-renin ratio measured. This is one point. I think this is not too expensive. Concerning reducing all medication, this can be really a problem in these therapy-resistant patients. But I tell you a little story from our experience. When we did the TRIO trial, there were apparently resistant patients coming with 7 medications, 6 medications. We stopped everything. We put them on a single pill combination with 3 drugs. They came back 4 weeks later. 90% had normal blood pressure, 90. And 10% were really therapy resistant. So I would be brave to stop medication in many patients because probably they don't take the 7 medications. That's a problem.
Thank you. I guess we move to the next speaker, Dr. Arif Nouriani.
Good afternoon, everyone. I hope everyone is still awake because we were quite scared yesterday that everyone would start sleeping after lunch. So, no, I believe, first of all, it was so nice presentations, paved my path to my presentation. And it is quite challenging. We've been struggling with renal denervation over the past decade. 10 years we've been struggling in our center, convincing patients to accept this kind of treatment because you could do it with a few pills. And now we have poly pills, so it makes the adherence much better than before. Insurance is a challenge. Certainly, I'm going to start my presentation as a clinical experience with a short video actually recorded. We had to shorten that video from 1 hour to 6 minutes, so forgive me for any shortcuts, but I have no conflict of interest. So basically, the pre-procedural medication have been already pointed out by our colleagues that this kind of renal denervation therapy is requiring conscious sedation or deep conscious sedation using analgesics and anxiolytic medication. For sure, we have seen that experience, how painful this could be during the ablation. And unfortunately, this is as well in both modalities. It is also recognized that this might require kind of increasing of the sedative just prior to the ablation. And then we have to maintain an ACT of 250 seconds. So to start the procedure, ideal would be a CT scan up front. That will spare you a lot of surprises during the procedure, but if not, an aortogram is certainly important, and then to be selectively doing an angiogram for each renal artery, and then determining the vessel length and diameters by QCA. And then also we have to mention that the Paradise balloons catheters are not unified. We have different sizes for different size of catheter. Here we can see the arteriogram on the left side assessing renal artery. Takeoff angle is very important, and the tortuosity, certainly the accessory arteries. And this is really challenging for us, even as experts in the coronaries. We face sometimes challenges by accessing those renal arteries. It's not easy. I wish to have some kind of radial approach for those cases, but yet we don't have that. And then placement of guide catheter, positioning guide catheter tip, bit deep as possible to get a better support, because we do have this kind of device delivering some kind of resistance, so you need some kind of support. And I use sometimes also extra support wires. And then the sizing here with our Paradise system starts from 3.5 to 8 millimeter, according to the table in front of you. We have two kind of delivery catheters so far here. We have the RDC and RDC1 and Lima for the inferior uptake. The procedure after our sonication is completed, the balloon will be automatically deflated and confirmation will be displayed. Procedure using one of the three different options. You can see the markers. That is very user-friendly. It can show you, it's all screening, touch screen buttons, and you can see the size of the balloon over the link side of the upper corner right. It detects itself, so even if by mistake the wrong balloon was handed over to you, you will be identifying, the system will identify it and apply the pressure that it is needed, and then you just follow the instructions as it is. So you will go to the video. It's a short video. I hope I can, I don't know.
How the balloon is filled and
so this is how we fill that with this cooling or hydrocooling solution, just to demonstrate. So it's a 5 millimeter emitter there, or transducer as mentioned.
The damage to the vessel wall directly.
This cooling effects, for people who cannot hear me very well, will avoid the direct heat or thermal damage to the renal artery. In this test, we could just inflate and give some sonication, and we can see very tiny waves or micro kind of waves that have been generated by the sonic energy. I don't know if you can appreciate that. You see there some kind of wave production.
Can we repeat? There is waves
generated
after delivering the energy by the balloon.
On the right side, we can see the generator. It tells you step by step where you are. Once you have inflated or cooling, it gives you the marker exactly step by step where you are. And then we use a 7 French guiding catheter. And here we can see easily deliverable balloon or the transducer. Here we use, by the way, a run-through wire. So we give some nitro actually. And then we do selective, diluting the contrast 50% to 1:1 ratio to reduce the impact of contrast as much as possible. In certain cases, we use also renal guard to reduce the impact on the kidney function. We could
this looks okay to me.
Position just 5 millimeter to 1 centimeter from the distal parenchyma. So the transducer is sitting nicely in this. You have to move, maybe find yourself a good projection where you could really identify the landing zone. We can give 2 to 3 or 1 to 3 ablations per each renal artery according to the length and the distance. Bearing in mind, we have to leave something like 5 millimeter, which is the width of the transducer marker between each ablation or energy delivery. So then we can go step by step, as you see on the left side. preparing the catheter with the cooling. This is pre-cooling, will start now. All we need to do is to connect there.
1 minute and 30 seconds.
And the size has been given here. 5.9 for this vessel was measured, but we have to check here by giving contrast after inflating the balloon, injecting contrast to see whether we are really blocking the contrast flow, so we have a good wall position from the balloon. We will see now. Though this went exactly as has been described in the table, the size was supposed to go with a 6, with a 5, because it was 4.9, sorry. So after that balloon was positioned,
Yeah, that is how it should look like now. So I'm advancing again, as we see on the screen.
there was a leakage, so we had to exchange the balloon with another one, a higher balloon, which was a 6.
We'll do a small puff, please.
That's a challenge with our current technology, that we may have to change multiple balloons. You know, the renal arteries have a really large variety of sizes.
So I think this is okay. We are at the curve. Can go a little back if we wish to, but I think we are fine. Here, can we inflate, please? We are more than 1 centimeter.
See, it's inflated. So
Test, please. So now we are blocking nicely.
Safe.
So,
safe.
Can we start?
So we'll have to inject. Now we are asking the anesthetist to give another shot of painkiller, so that because the patient will start moving actually. It's expected. We had experience also with the RF technology. We have the same, exactly the same. So it is really some kind of painful procedure for someone who tried it.
Patient's moving a bit. Our anesthesia is giving some more painkiller.
We see the movement on the left side, the patient's moving his legs.
But they sense this. And now deflating the balloon again.
So
as we can see on the monitor, very clear.
then it will, after giving the 7 seconds of ablation, then we go to the deflating or post-cooling and then deflating. So it goes automatically. You have to do nothing here.
Give it time. No rush. And then I'll go back.
If we have an accessory artery, has to take only one sonication as per protocol. Now we moved proximally for the second inflation. We have to keep distance from the origin of the renal right of the artery. We should not be touching the ostium, keeping at least 5 millimeter distance. Mild stenosis shouldn't be a problem, but shouldn't be a moderate or severe stenosis at the area of the energy delivery.
One transducer away from the ostium of the renal artery, away from the
and maybe just a bit. We are just.
Yes.
This may be better. Yeah.
Perfect.
Okay. Can we save that one, please? Okay.
Maybe
We can.
You should hold the catheter while he's inflating.
Yeah. Go ahead, please.
So we'll start inflating the balloon.
The monitor again.
Inflated.
Has been demonstrated nicely on the generator on the left lower corner.
It's blocked nicely.
We can inject.
Let's start.
And there was no leakage there.
Yes, sonication, please.
It takes exactly 7 seconds.
Again, we are expecting patient to move.
So this is the pre-cooling phase again.
So
now starts, and we'll see the patient. Again,
twisting his foot a bit, but it
much
is
better.
Really well controlled.
Now we'll go to the post-cooling, and then comes the deflating of the balloon. We should take time, not to rush pulling that balloon, and that's it. So In summary, hydrocooling helps protect the inner arterial wall. The Paradise System SonoWave 360 transducer delivers a complete 360-degree ring of energy, targeting approximately 80% of our sympathetic nerves around the renal artery. Each delivery of ultrasound energy is just 7 seconds, and only 2 to 3 treatments per main artery are needed. It is an intuitive generator with simple, user-friendly interface with ultra-efficient workflow. With this, thank you very much.
Thank you, RF, for the excellent demonstration. Now I think that everybody knows how the device is working. Any question to RF? Question here. Can we have the microphone, please?
Hi. So I just wanted to ask maybe a bit of a controversial question, but do you think the ultrasound will be the way to go for renal denervation? Given that you have to do your ablation within the main branch or the main renal artery only, you don't have to go into the branches, so there is less manipulation, potentially less harm. The other thing is with the ultrasound as well, it can penetrate a little bit deeper into the tissue just regarding the biophysics, and you get some intimal sparing as well, as compared to the direct thermal injury of RFA.
Thank you very much for that question. Actually, this is our initial experience. And bearing in mind, we started this just a few months ago, and we had so far stuck to the protocol that had been provided to us through the company. So we didn't go so deep. This was the recommendation. And we do worry about the parenchyma injury. It is a thermal impact, so there might be some injury. So we don't want to go to that extent. And besides, if I can mention our experience, we had done something like 6 cases so far. And I can tell you one maybe didn't have interest to come back to us for the follow-up for the investigations, but 5 of them, 2 of them had reached a drop of 2 of their medication, 4 medicines that they used to take within 4 weeks, although the expectation is 1 month to 3 months to have the impact. After 3 months, maybe you get that kind of result. But we had surprisingly 2 cases that were controlled, and we had to stop 2 of their medicines and with good blood pressure control, which was checked by the ambulatory blood pressure, 24 ambulatory blood pressure, certainly. And 3 of them, they were controlled, but after 3 months. So that's that.
Thank you.
Thank you. And I think, correct me if I'm wrong, but I think you want to see some initial reaction in the intima, or a little bit deeper also. Those bumps or stenosis that you're calling, actually, it's a favorable thing. You want to see immediate reaction. So you know that your energy is getting there and there is some tissue reaction.
So first of all, this is different than RF. In the RF era, I remember we used to do even OCT or even imaging to control our what we have done. We want to see that we have caused some kind of scar, burning, some kind of tissue damage or something. In this technology, you don't see that, frankly said. You have to wait and see.
Thank you.
Sure.
Thank you, RF. So, pleasure to, a little bit later, sorry, to leave the microphone to Dr. Joachim Weil, talk about patient selection, referral, and how to set up a RDN program.
Yeah, ladies and gentlemen, first of all, I'd like to thank the organizers to give me the chance to escape winter time in Europe, to come over to Dubai. It's great to be here, interesting meeting, and it's my honor and pleasure to talk about patient selection and referral pathways. To be honest, we have built up renal denervation programs 2 times. One before hypertension 3 trial, which was easy, and the second one after hypertension 3 trial, which is really difficult. And this is my conflict of interest, and here's my agenda. So I will briefly go into patient selection because we heard already from our colleague in Kuwait how to do it. And then discuss with you the key steps to build a referral network, which I think is very important if you have a program doing renal denervation in your hospital. And then I like to also show you some challenges and barriers and give you a solution to overcome these challenges. So let me start with insights into the target population. For clear, the resistant hypertension group is the one we should aim for, and it's in the current guidelines right now. It's a class 2 indication for the European Society of Hypertension, but also for the European Society of Cardiology. However, the patient with uncontrolled hypertension and end organ damage, they also have a very high risk, and they have the highest benefit from reducing blood pressure. There are very good data out on this. But what should we do with the ones who are non-adherent, or even with the ones who are uncontrolled and intolerant for medication? We need to offer some therapeutic options for them as well. So why resistant hypertension? Because they have a real high risk. And this is shown on this illustration here. You see the non-resistant hypertension group, the mortality over 20 years. And look what is the apparent resistant hypertension group. Mortality is 2 times higher. So they probably will have a big benefit from doing, to control their blood pressure. That means having combination of pills, lifestyle modification, and nowadays renal denervation. So when you start a program, you have to identify and engage the stakeholders of such a program. And which are these stakeholders? First, the family physicians, because they are probably the ones who see the patient first. But then you have the cardiologists and nephrologists who are using specialized to manage difficult to treat hypertension. And the nephrologists also look for kidney-related causes of hypertension. But we maybe also look for the internal medicine people, because they often have patients with hypertension in their office. And last but not least, we have the interventionalist who's doing the procedure in the end of the day. So how to develop an educational program? I think you have to educate the family physician, the specialist, but also other departments in your hospital if you start a program. For example, neurologists who see a lot of patients with hypertension and complication. They have stroke, for example. So this is another way to do it. How to do it? You need to have criteria for referral, inclusion, exclusion criteria, mandatory diagnostic workup. We had this before. Do we need to look for secondary causes? I think yes, not every secondary causes, but these ones which are relatively frequent. So then we have to discuss the benefits and risk and the evidence, what we did today, the evidence from scientific work to support renal denervation. And the solution to this is to do hosted continuum medical education events like webinars or rounds in your hospital, publish consensus documents. So far as I know, there's no document in the Arabic world for renal denervation. But as I heard, it's under the way. I think it's always very helpful for everyone having such a consensus document. And then distribute clear referral guidelines to your referral physician. An example would be having regular workshops on this topic. So this is how we did it. We had a stepwise development of our program. We set up a center plan, and it's relatively easy in Germany because we have a certification process. Right now, there are 20 centers all over Germany who are certified to do renal denervation. And there are some prerequisites which you have to offer to become a renal denervation center. Then we had a foundation of a multidisciplinary team, including nephrologists and endocrinologists, as we saw before. And then we identified referring physician and started our internal and external education and communication. And this is the pathway we have, and you have seen this slide a similar way before. This is the regular pathway. Patient comes to its family physician. Family physician is not able to control blood pressure, sends him to a specialist. He checks for other reason for hypertension, and then maybe send them for renal denervation to the hospital. But nowadays, there are other ways, less typical pathways as well, because patients directly go to the specialist or even to the interventionalist, as we have learned it from the studies we have performed in our hospital. So Don't forget, send the patients back to the referring physician. You have to really closely communicate to your referring physician because we all know we have a 30% non-responder rate. So there's a lack of awareness and knowledge after hypertension 3 trial. So we need to educate not only our physicians, but only the patients about the procedure and its potential benefits in uncontrolled hypertension. We can use public campaigns for that, brochures in the clinic or social media. And I think it's important to monitor and evaluate your own performance. And you can collect data on your number of referrals, success rates of the procedure, and so on. And I show you what we have done in the commercial cases the last 3 years. And you see it here. This was 73 patients. You see there were about 70% male, mean age around 60 years, 25% non-responders. Wherever you go, you have 25% non-responders. But these patients are in a program. They are not in a trial. We follow them very closely. And you can see the baseline blood pressure in ABPM, systolic, was 151 and 89 in the diastolic blood pressure. And we reduced the blood pressure by 17 millimeters of mercury without changing the pill burden. Pill burden was 3 pills before the procedure and 3 pills after the procedure. No statistical difference. But the effect we see when you really follow the patient carefully, doing optimized medication and renal denervation is maybe higher than in the trials. So why programs fail? I think these are the top 3 reasons. Skepticism toward effectiveness. So initial trials, as we have learned today, have shown renal denervation does not work. And that's still in the head of many of our colleagues. So solution, we need to share the updated evidence, scientific evidence on this topic. There's some referral resistance from specialists, especially the nephrologists. They're afraid about destroying the kidney or hurting the kidney by renal denervation. What is the solution? We need to provide them with the safety profiles, and there's no signal so far showing that it's bad for the kidneys. Actually, there's some data out showing that the reduction in GFR is even slower after renal denervation than the natural history. And then we have patient hesitancy. So many patients are feared about an invasive procedure. There has been some surveys in Japan, in US, and Europe. They showed that about 30% of the patients who have an indication for renal denervation want to have an intervention instead of extra medication. So with other words, not everyone wants to have an intervention, at least in this country I mentioned. So we need patient-friendly education materials and maybe real-life success stories which we can publish. And the take-home message of my short presentation is building a robust renal denervation referral requires, first, careful selection of the right patient. And we can have this as a discussion in the next 12 minutes, maybe, who is the right patient in the beginning. A clear referral protocol, so your referral knows what he has to do, where he has to send the patient, and effective collaboration and communication. That's very important. Communication between the specialists and ongoing medical education, as I showed, addressing all the logistical, patient, and insurance concern might come up with this procedure. So by creating awareness and overcoming these barriers, the network can ensure that more patients with uncontrolled hypertension receive the benefits of renal denervation. Thank you very much for your attention.
Thank you very much for your really eloquent and short presentation, which is very enlightening. Now, we learned a lot today about renal denervation selection, procedural steps, some clinical outcomes. But when it comes to reality, you are ready to do and start your program. And when you do the first patient, it actually dictates the history of how to proceed, whether it is a complete failure or a complete success. And if you have a success, it's not only for the patient, but to your own potential morality and push for the technology. How do you do that? Which patient you think that will give you the best satisfaction as a physician and best satisfaction as a patient to reflect on the effectiveness of the new technology?
Yeah, I think that's a very interesting question. That's the most important question when you start a program. Yes. We had this in the very beginning. I think the gentleman already left to ask, do we have markers? Yes. We do not have markers so far, except the blood pressure when they enter the program. There's a clear correlation between the baseline blood pressure and the response of renal denervation. It has been shown in many publications. And so I would recommend for yourself, look for the ones with 6 medication, not being controlled, having office blood pressure of 180, maybe higher, 180, but confirmed by ABPM. You don't want to have a white coat hypertension patient in your group when you start this program. And when you have had these really difficult to treat patients where nobody knows what to do with them, you will probably see a very good reduction in blood pressure. And then from then on, you go maybe also treat more complex patients with lower blood pressure, because as we learned in this session, every millimeters of mercury really counts. You have shown this in the beginning, 2 millimeters of mercury reduction, 10% reduction of stroke. And we have learned the same actually from the Chinese people when they reduced salt in their nutrition. 2 millimeter mercury less, 25% less stroke.
Okay, well, we should look for a patient like Russia's patient, so we have a really very good start.
Ahmad, I completely agree with his statement. The first patient is the key,
of course,
okay, for the success of your program. Like when we started our program recently, a few months ago, the first patient that we enrolled, her blood pressure systolic between 180, 200, and diastolic 90 to 100 on 6 medication. And she was compliant. We make sure that there is no secondary hypertension. We make sure she's compliant with medication as well, with follow-up. And then we did her procedure. She was our first patient. Today, she's down to 4 medication, and her systolic blood pressure between 120, 130, and diastolic 70 to 80.
I think this is an important message for any new technology, not only to renal denervation, because first patient sets your morale and sets your expectation.
Actually, I think everybody here, I think most of the people here, they have experience with this for the last 12 years. And actually, I don't want to say that we are reinventing the wheel. I'm really sorry for this. But I think, yes, we have stories with patients who really responded very well to this, but I think there are many factors actually we have changed. The one that you put in the study, or you put them under focus for renal denervation, you change many things, and they play a factor to get a better result. I think what I don't know, I really, if we have an answer for this, why this is a nerve conduction problem. This is a nerve problem. We need electrical, not ultrasound, not anything else, until we have something as a marker for the nerve conduction to the distality of the renal artery. Why not to have something like this and to show that really this nerve is not conducting anymore? I think this is the way how really to say this procedure is really successful and it did a difference.
Right. Well, from histology and pathology, they demonstrated that in animal models. So that's, but I think now
human being,
everybody...
Because this is the same as the cardiac ablation.
Let me finish.
Everybody
agrees we need markers, but are these realistic markers? Do we need biomarkers? Do we need imaging markers? This is the question.
Interesting question. Ask every time when I give a talk or when we are sitting together on renal denervation. So first thing, people are working on this. Second thing, we have the problem of the heart. The heart is a strong electrical organ, and it's much stronger than the signals coming out of the nerve. That's a problem. And on the other hand, we're doing PVI, right? You do PVI in your department. You know what you're doing. You know you're in the end of the procedure, everything is closed. still you have 30% relapse of atrial fibrillation. So you can also ask, do we really need markers? The only thing we might need markers is because we want to have a pre-selection for our patients because it's relatively expensive.
Okay, I have a technology question now.
I think, Ahmad, just 1 second. I think this is, I think we need to take out our interventional hat. We're used to having a severe stenosis. It has to be fixed. You have to see a good result immediately. For blood pressure, I mean, we've been treating blood pressure for a long time, and you know that when you improve the medication, it takes time.
Yes.
So we have to get used to that this technology will result in gradual improvement of blood pressure. I mean, you will see it in a number of cases, not everybody, as you have clearly indicated. So remove the interventional hat to see a result immediately. I mean, you will see it in a month time, in a 2 months time, and as Russia has shown and others in years, 3 years and 10 years time.
Yeah, you should look for long term.
Ibrahim, with this technology, we have to be patient. Yeah.
Patient, not doctors.
A question about...
Now, the technology question, do you want to answer?
No, I have another question, so you can answer.
Okay. Now, the ultrasound renal denervation, it depends on the balloon, but we now have balloon materials that can be flexible, which can really accommodate to the artery itself, and it depends on the volume rather than the size of the balloon itself. So you can really inflate it with different volumes, and it can give you different diameter. Is that something applicable to your technology? Because will simplify the procedure. If you get to this material and it accommodate from 3 to 10 millimeter with just volume dependent, you don't need that complexity of different sizes and CT before and so forth. So it is a low pressure volume mediated balloon size rather than fixed size balloons. Anybody?
Record people, you have any answer to Dr. Ahmad Haddad?
Yeah, I can probably comment on that. So yes, this is the next step of the development, to develop more balloon with a compliant material to overcome the need to exchange the balloons during the procedure. Okay. But even so, I have to say right now, in our procedure, on average, we need about 1.7, 1.8 balloons, not more. But the future is truly, one is transradial, and 2, together with a one-size-fits-all balloon.
Everybody is moving from femoral to radial. Do you think radial approach is essential?
Absolutely. I think radial is, for me, this procedure, as you have indicated, the simpler you make it, the more adaptation of the technology with the people who are going to treat hypertension. So radial and compliant balloons, that you reduce the number of balloons you need to ablate. These are 2 requirements.
Okay.
One comment to the radial approach, if you allow me. If you do radial, you have to do it from the left side, because otherwise you have the risk of stroke. There's a small risk, but you cross the aortic ascendance. And when you come from femoral, there's no stroke risk in doing renal denervation. But when you come from above, there's a small, but still a risk for stroke. So I would then recommend to do from the left arm.
Yeah, that will take in. Rasha, we have a question.
Just a question to you about the non-responders. Have you ever attempted to do a different modality after that? So if you used RF first, you would do ultrasound, or the other way around?
So I didn't get the question.
Can we redo renal denervation? And if you do redo, is it the same technology, or you recommend different technology?
I can't answer this question. I never have done it because it's not paid. First reason. So when you want, there are some case reports outside. When you do it a second time, I would recommend to do it with a different technique. Maybe we need a pilot trial on this, on so-called non-responders, maybe to repeat it. I don't know.
Actually, I had one patient who had a different device modality, but was that 10 years ago, okay? And initially she responded for about 2 to 3 years, and then she became out of control. We used the different device technology, and she is doing well. We have been following her now for the last 4 months. So that's one patient experience, but I think it raised the question to me, do we need to repeat that procedure? Are the sympathetic nerves grow again? So, because initially she responded well to the...
But that was the old...
Yes, yeah, that was 10 years ago.
Which is unipolar radiofrequency,
yes.
which is understood.
One explanation for redo after first ablation. It's not about you didn't ablate very well. It's because other system, it take over and compensate the neural system from the ablation. So maybe you don't need to ablate again, just play with your medications more.
I have a question. So right now, a lot of centers, they have the simplicity system. So if this is a device-based question. If I have both systems available, which one should I use? I mean, I'm already using a system that is effective. I know it's effective. When would I use this system or that system? Is there did someone have this dilemma in their center yet, or it's still...
The simple answer is that we
You
don't
should have
know.
both. You should have both, and you give us the answer next year.
I think we are running out of time, but I want to ask here, after this nice symposium with a lot of explanation, who would consider renal denervation a program at his facility? Wow.
So successful convincing. Well, colleagues, thank you very much. I think this was a wonderful session from our side to have both major players in the renal denervation side by side, friends talking about enhancing the therapy for all the patients to benefit all. And I think we heard a lot of good news. With that, I would like to ask Dr. John Fajadeh to tell us the conclusion.
No, just a short conclusion, less than 1 minute. First of all, I am really convinced by this technology and this new treatment for the patient with have a high hypertension, resistant hypertension. Why? Because it's a safe procedure. It's a simple procedure. It's effective, we show that. And we have the possibility to use different devices. So I think that there will be a bright future for this technology. For me, the main issue is the recruitment of patients. There are a lot of patients around us who could benefit from this technology. The problem is how to convince the patient, convince the general practitioner, convince the different, practitioner, nephrologists, radiologists, etc. And it's true that if we could have special art center with a specialist focusing on the treatment of hypertension, this would be certainly the key solution. So I would like to thank, because I think it's the first time Medtronic and Recall to give us the opportunity to share together this really fantastic technology. Thank you very much.